Dr. Rand's laughing because I'm holding the camera today. I don't have the tripod.
We're going to test to see if Dave has any fibers, but for 2A fibers now.
Steady hand.
See how steady it is.
Steady hand. All right, Doc, we're back, and we have some brand new questions for you today. Good to see you, man. Last time I saw you was right around the beginning of the quarantine. It's been a while. So
yeah, I hope it's not because of quarantine. We've just been busy, right?
No, we've been busy. You've been busy. Last time I came here, you were actually in Idaho.
Yeah.
You were visiting a vacation, whatever was going on over there. So now we're back in Santa Monica, and we have some good questions, including from women, which you love.
Yep, we finally got a couple good ones from the ladies. Thank you, ladies.
Awesome.
Please don't be shy.
That's right. So I'm going to let you take the first one.
All right. So, well, this one is not from a lady, the first one. But the first one says, hey, Dave, thanks so much for your work with Dr. Rand McLean. I'm not sure if you're still working together with him. Yes, we are. In the Ask the Doc series. But if you are, I have a few questions for him. Hello, Dr. McLean. Hello. I recently stumbled upon the Ask the Doc series on YouTube. I cannot say how helpful it has been to get a clinical perspective on fitness science, particularly regarding the ins and outs of physiology and chemistry. Well, thanks. And it's definitely been our pleasure. We're having a lot of fun. We were just talking about it over lunch.
Yeah.
I have two questions. First is regarding blood tests for baseline before starting TRT. What do you recommend getting tested for to get a thorough and complete baseline? In my mind, it would be things like CBC, which is a complete blood count, CMP, complete metabolic panel, comprehensive metabolic panel, liver enzymes, testosterone total, testosterone free, estradiol, prolactin, sex hormone binding globulin, GHRH, GnRH, those are growth hormone releasing hormone, gonadotropin releasing hormone, FSH, follicle stimulating hormone, LH, luteinizing hormone, T3 and T4, those are thyroid hormones, and then question mark, other steroids. So I don't know if I should at this point, as we always disclaim, we're not here to give medical advice, but just some general knowledge, if you will. It's a kind of a loaded question because if you're talking about a complete, thorough baseline, everyone's got their different opinion as to what is as a baseline. I am probably infamous, notorious, whatever, for at phlebotomy stations for getting maybe more than the average for baseline. Our so-called basic panel is pretty comprehensive. And that's kind of a no-no in medicine because you don't want to approach the human body in medicine, at least we're taught not to, like an engineer would. You don't want to go looking for trouble. You don't want to dig up things necessarily that aren't worth digging for because, as I like to say all the time, you don't treat numbers, you treat people. And sometimes you might dig up a number. For example, we used to get prolactin on our labs a lot. We used to get a highly sensitive C-reactive protein. The prolactin is because, as you know, it affects hormones. It can affect, if it's high, it can affect your ability to produce testosterone. It can also affect dopamine, a neurotransmitter. So it's nice to know if it's high or low, but in relation to a complaint. And that's the problem. If you go looking for trouble, like we found out, a lot of people on replacement therapy tend to have a higher than normal, 2, 4, 6 points above normal prolactin level. And we don't necessarily know why, we just know it's correlated. And it's not a problem, but it makes for a lot of unnecessary gnashing of teeth when people see, oh, it's high, it's above normal, what do we do about this, doc? And we have to do some explaining and then wait to retest it or not. And it brings up issues that don't need to be brought up because it's not harming anybody and no one has any complaints related to it, but it shows up on a lab. So that's just an example. And same thing with C-reactive protein. Most of our clients here, our patients are athletes. So, they might come in and get their labs drawn after a serious bike ride or a morning workout and their inflammatory markers are going to be elevated. It doesn't mean they have heart issues, okay, which the C-reactive protein, highly reactive, is sometimes called C-reactive cardiac because its relationship to a likelihood of having heart disease, particularly coronary artery disease. Well, that used to come up and we have to say, wait a minute, don't work out for a day or two and go check it again. And of course it would become not only within normal limits, but on the low side because most athletes are pretty healthy, at least the ones we're dealing with, who are doing everything right, etc. So sorry for the preamble. The ones that you speak of here are good. They're, with the exception of SHBG, GHRH, and GnRH, those are all, and the prolactin I mentioned already, Those are all on our so-called basic panels anyway. Some of these, like let's take for example GHRH, I might order something like that as we get further into an issue, but at the end of the line, if you will, is growth hormone. And really, we're not going to wake you up at 1:30 in the morning to check your growth hormone. Growth hormone lasts for about half an hour, and then when the liver processes the GH, it'll manufacture some IGF-1, and that lasts long enough to test it the next morning and give us an idea. It's used as a surrogate of what your growth hormone levels are. I don't necessarily need to dig into GHRH from the start. I just will check your IGF-1 and see, okay, is it within normal limits, or is it apropos to what you're trying to do with your health right now? Meaning, is it high or is it low? Don't really necessarily need to dig into the GHRH in, say, a 50-year-old guy or gal. Maybe in a pediatric patient or somebody younger, we might have a reason to look at that because it's off and we don't have a good explanation. But anyway, so some of these I wouldn't necessarily put on there. They're an expense. SHBG is one of the favorites that's on a lot of hormone panels when people are going in for testosterone replacement therapy. I don't like to look at it because I think it's a waste. If you have a high free T, by default you have a low SHBG. When taken in context with a total testosterone, which I always grab with a free T, because obviously you could elevate your free T in an absolute way by just using tons of exogenous testosterone. But we know of a relationship there, roughly 2%, and so I think that's kind of a wasted number or wasted assay. So to get to the bottom line, the things I would add to this would be, we like to look at another hormone we call vitamin D. I like to look at progesterone. It's not a sexy hormone for men or women, but progesterone is a necessary hormone. It's part of the cascade of hormones. It starts with the steroids, cholesterol. I say it's not sexy because, unlike testosterone, it's not going to give you a lot of vigor. It's not going to help with your libido necessarily, but it has a function, and men and women both need it in relatively the same amounts. It can be used, especially in oral dose, to help with sleep. So, again, I'm just giving you a rationale for some of these anyway. Pregnenolone, another one that's not a sexy one. It's relatively speaking the first one off of cholesterol that can be converted to other hormones down the cascade. Pregnenolone is known to help with cognition, appreciation of color. Again, not necessarily the sexy ones, but if you're low in any one of these hormones in this cascade that begins with cholesterol, more than likely, if you're an older patient, you're low in some of the others too, and why not address those? So it's nice to have those numbers. Let's see, liver enzymes. Well, that's a touchy one because AST and ALT are not necessarily only generated from breakdown of a liver cell, contrary to popular belief. A lot of athletes, particularly well-muscled athletes, will have mildly elevated AST or ALT, typically ALT, but sometimes AST as well. But it's not from liver. So we get a GGT, so we can differentiate. GGT is created only by liver, pancreas, biliary tracts, and not by muscle tissue breakdown, is my point. So I get that so we can differentiate between the two. Some people come in maybe who either have a genetic predisposition, or they drink a lot, or they haven't been working out like they want to now embark on a new program, and they might have a fatty liver. AST and ALT enzymes can be elevated for something like that. But again, a GGT thrown in there helps us differentiate that before we go off on an unnecessary tangent, if you will, getting either on some MIC caps, we've talked about this before, methionine, inositol, and choline particularly, or getting an abdominal ultrasound to see if there's a fatty liver. So, you've selected the basics here. Can't really add much to a lipid panel, almost really for legal reasons, I hate to say, because we now know that we've talked about this before. I won't go off on lipids and coronary artery disease. It's definitely an issue It's definitely, there are definitely assays you want to look at if you have extant coronary artery disease, but not necessarily if you don't. But that said, a standard a lipid panel, while you could argue is not very worthwhile, it still has a triglyceride assay to it, which is worthwhile pretty much no matter how you slice it. But today's standard panel is not very useful. Just to get an LDL, a so-called bad cholesterol, not very valuable. Better to get an LP little a, an LDLP. Ditto for an HDL. They're nice to look at and they're relatively cheap, and they come with, the rest of the lipid panel. We're looking at triglycerides, which I would argue is always valuable to look at. LDL and HDL not so much, again, in the standard panel. So I would add that to your list. Also, you mentioned here T3 and T4. I'm not necessarily interested in just the totals, because just like with total testosterone, it's not the active number, it's the free testosterone where the rubber meets the pavement. Free T3 I would ask for. So a total T4 and T3 and a free T3 as well as a TSH, valuable to have. Again, I'm giving you a basic panel for someone who comes in and says, hey doc, I'm not feeling as good as I used to. I don't necessarily have any real serious or specific complaints other than, I don't have the energy, libido, good mood I used to. My body composition is harder to change than I used to. These are standards for my practice, more or less. But, there might be others that I add to that if they have other complaints. And that's the way it's supposed to work with medicine. Add the labs based upon the patient's chief complaints. So I guess that's all I would add to that. And hopefully that wasn't too long-winded. But we certainly have no problem posting our standard panels and our so-called comprehensive panels online. If we haven't already, be happy to share. But without getting too further into long-windedness, I'll stop there.
Awesome.
Wait, he has a second question though.
Oh yeah, that's what I thought.
This guy's, we don't have a name, so I can just say this guy. He's done some digging, and he says, the second question, I have found that clomiphene citrate, is a combination of enclomiphene and zuclomiphene. Enclomiphene increases serum T, LH, and FSH in male studies at 25 milligrams a day for short and long-term usage up to 6 months. It can go longer than that too. Zuclomiphene acts as an estrogen receptor agonist, yes. Ratios of zuclofamine to enclofamine can be 20-1 after 6 weeks of treatment. Not to mention the genotoxic / cytotoxic effects of zuclofamine. Sorry. Wow. I can't find enclofamine alone for commercial use, only research. Is there a way to eliminate zuclofamine from your system, perhaps with a competitive estrogen receptor antagonist or other means? So there's going to be a lot of people who are going to fall asleep during this part of the video, but this is actually a pretty cool question. He says, any information, structuring, or guidance you're able to provide would be extraordinarily helpful. As I mentioned, this information is difficult to find. Yep. Again, thank you so much for your vast well of knowledge and your willingness to teach it to others. Much obliged for the thank you. And we do it because we like it. Also, unrelated note. Oh, this is something about my homepage. Well, I'll read it. Also, unrelated note. Thank you for being thorough and checking on this. I actually do appreciate this. He writes, the caption beneath your picture on the psrmed.com homepage reads, quote, and has worked with some of TH best and original innovators in sports. Looks like we left out an E from the the E, it says, the is missing the E. Thank you for noting that and for alerting us. So we'll jump on that. And he says, thanks again. So with clomiphene citrate, yeah, you've got a combo drug there. I want to say it's like, 70-30 roughly in there or something, one versus the other. And the zuclomiphene acts to what we call agonize the estrogen receptor. So it works like estrogen, which is no bueno. I agree. And it's one of the reasons why when, and I can't prove this in a study because none has been done to prove it, but I suspect that one of the reasons people have such a bad outcome when it comes to using clomiphene, meaning they feel horrible, is because some people react to that negatively. In general, estrogen is not our friend, certainly in excess. And there's some estrogens that never are our friend, but excess estrogen tends to make you feel moody and irascible, bitchy as it were, to use the vernacular, whether it's in men or women, but more so in men, I argue, because men aren't used to having higher titers of estrogen. So when we use clomiphene, in men and women, because it's used as a fertility treatment in women also, they can have side effects of just a malaise, we'll call it, just not feeling good. And yeah, so if we could eliminate the zuclomiphene, that could be helpful. Again, this is a drug that's called a selective estrogen receptor modulator. So some receptors are going to be blocked, and that's going to be by the enclomiphene, and that's what we're looking for certainly with men in terms of TRT, or endogenous production to treat hypogonadism. I dare not get too technical, but we've identified many estrogens. There's at least 25 in a general category we've identified, and subs to that too. But there are estrogen receptors alpha and beta that these two work on, and one, the zuclomiphene, activates the estrogen receptor alpha. The other antagonizes the beta. And the upshot of this, without needing to get enough information to get on and win Jeopardy, is just that clomiphene, when it's used in males, the antagonistic effect on estrogen works well enough that as long as there aren't any side effects, it's tolerable, that it can treat hypogonadism by encouraging the production of LH and FSH from the anterior pituitary. The upshot being, again, you can increase your testosterone as well as your fertility. So this gentleman wants to get the ultimate, which is the enclomiphene portion, just the antagonism of estrogen alone without the other. One of the reasons, by the way, just a quick note, that there's a 20-to-1 ratio after 6 weeks of treatment is because I'm assuming after you withdraw the drug, it's because zuclomiphene has a longer half-life. So normally, as I said earlier, it's roughly a 30-70 combination. So that's just because of the half-life. It doesn't mean it's less of a problem, but this is a little bit misleading if you take it, as 20-to-1 at face value. But anyway, enclomiphene, I believe, there's a brand name for it which escapes me right now, Andra something, but you can get it. It's not FDA approved. Neither is clomiphene for hypogonadism, but it can be used off-label, and I would try to obtain it if you're interested, obviously through your doctor, but through a compounding pharmacy. I think right now the biggest issue with enclomiphene is that we can't find an FDA-approved source. Okay, and that's important. If somebody tells you otherwise, be careful of the pharmacy that you're dealing with. It should be from an FDA-approved source. But I think it is findable. I'm not sure if this is, and you can edit this later if it's not kosher, but Empower Pharmacy out of Houston, Texas, a federally licensed pharmacy, I believe they're looking into it, and they're usually pretty good about sourcing these things that, again, would definitely be a better alternative to clomiphene for the reasons this guy mentions, but they only find it from reliable legal sources. So that's at least one place to look, and I think that answers the question here. Basically, clomiphene is still a SERM, but it acts in such a way, which is, I think, the point here, that there's no stimulation, no agonism of estrogen receptors, only antagonism, which is a little bit cleaner, if you will, and should prevent side effects and should help to promote more testosterone release through, again, the LH FSH mechanism. Testosterone is more of the LH, only the LH mechanism, but fertility through the FSH and LH mechanism. Then would obviously something that still allows you to release some of the estrogen.
Awesome.
Or your body perceive it that way anyway.
Thanks, Doc.
So second question is from Rory. He says, "Hi, Doc. I have done a few cycles over time, and I acquired small-ish gynecomastia beneath the nipples. Aromasin 25 milligrams a day doesn't seem to do anything like reduce the swelling. I have Letrozol on hand. Will this reduce the size of the gyno and the sensitivity during cycle? I am currently on 300 milligrams of testananthate and 400 milligrams of masteron per week." Good question. Typically, once you have gynecomastia, you've got it, and the only way you're going to get rid of it is surgically. The issue, though, is it necessary to remove the gynecomastia? No, it does not increase the chance of, say, breast cancer. But I ask patients two questions. Is it bothering you cosmetically or physically? Meaning, are you bumping into things? Are people bumping into you and it causing you some distress? In either case, it's a pretty simple procedure to have it removed surgically. I do it here. There are general surgeons that can do it. There are plastic surgeons that can do it. I'm not downplaying the use of a plastic surgeon to do it, but what I am saying is it's not a very complicated procedure. We're not going deep into the body. It's just below the skin. We're removing not just, and this is to help if you do go seek out surgical help to treat it. You don't just want to remove the breast tissue. Make sure that the surgeon has some history dealing with gynecomastia, because if you just remove the breast tissue, it often looks like someone, placed a divot there. You remove this and you're left with a big hole. You want to, at a minimum, sort of bevel the edges, if you will, by removing some of the fat which typically surrounds the breast tissue. And, you can go for the whole enchilada. And if, like some guys, that's a place where you store your fat, like this, the so-called love handles. You can use what effectively is liposuction to do more than bevel the edges. Just remove the breast tissue and all the fat up and around the nipple. It's not a dangerous procedure as far as procedures goes. It's a surgical procedure. It can be done with or without anesthesia, general anesthesia, that is. In other words, it can be done under local anesthetic, very safely and easily. Outpatient procedure. Typically, sometimes they'll put in tubes for draining. Sometimes they're not necessary. You can be back. Generally, they'll tell you, again, a plastic surgeon will probably tell you, stay away from anything, that uses that area, chest press or something like that for 6 weeks. A general surgeon will probably tell you 10, and I'll tell you, you can probably get away with doing a lot in just 4 days, depending upon how you do with inflammation and stuff after surgery. So it's not that big a deal. But if you don't want to go the surgery route, typically using an AI is not going to do much. The best thing you can do, because it works faster than an AI, because an AI is blocking the conversion from testosterone into excess estrogen, a SERM, tamoxifen is my favorite, jump on it right away. We're not waiting for the estrogen levels to drop down over 3 or 4 days. We are blocking the receptor within, not minutes, but hours, literally, when you take tamoxifen. Because the sooner you can jump on it, the less likely it's not going to grow anymore. And there is some recession of the early growth. But unfortunately, typically by the time you notice it, what feels like a pea-sized growth is, when you get in there, like a golf ball, or at least a marble. So that's the, don't shoot the messenger. That's the unfortunate news of gynecomastia. You're probably, if it's bothering you, have to deal with it surgically. But you can certainly keep it at bay. I wouldn't use Letrozol. Letrozol was the first AI invented, and then they found that there were some liver enzyme elevations, and then they invented anastrozole. Letrozol is just too harsh. And it, like I say, it's the same mechanism. So you're waiting for the estrogen to drop. As soon as you notice it, get on a SERM like tamoxifen. And if you have to use Letrozol as your AI, something else is wrong, and we should address it. Let's see. Aromasin is a different type of, call it estrogen blocker. It's what we call a suicide inhibitor. It's like an AI, and I would liken Aromasin 25 milligrams to anastrozole 1 milligram in terms of effect. He asked, will it reduce the swelling? If you have excess estrogen currently, then yes, anything to reduce the estrogen should reduce some of the swelling. But the gynecomastia itself, like I say, once it's grown, it's grown. You might see a little recession, but not that much. And the other thing I would say, just as a fun fact, is at least one study shows when you use a SERM like tamoxifen in combination with anastrozole, you'll typically reduce the effectiveness of the anastrozole itself by, I think it was roughly 13%. So just keep that in mind. It's probably more of a fun fact than it is a practical one. But typically you want to use one or the other. The other thing I would add is so that you don't have to use a systemic SERM with an AI. For example, you're using an AI, you think you have it managed, that is your estrogen, and all of a sudden you start to feel sensitivity in the nipples. Instead of rushing out and getting a SERM like tamoxifen, they make a topical, so you get less systemic absorption, but you can treat the receptors that are right there. You can apply it in the nipple area, and I'd say arguably that's a better alternative because of what I just said. It came to mind because you won't be affecting the anastrozole that you're already on, presumably as part of your baseline treatment, as much if you put a topical, but you'll still be treating what you're trying to treat. Hope
awesome.
That makes sense. Yeah.
Very cool. All right, girl question.
Yes, we have our first question from the ladies. Her name is Brittany. She says, hello, I'm a 35-year-old female, 5'2", 150 pounds, and wanting to lose weight and get strong again. I have years of experience lifting weight, but as I get older, getting as lean and small as I was, 115 pounds, size 2 to 4, is getting harder and harder. Right now I'm 150 pounds, but carry it very well. I'm small and curvy, but I'm used to being small, curvy, and cut. I wanted to try Anavar and human growth hormone together to give myself a boost, but can't really find any solid information on how to safely do both at the same time and how long to do them both. I'm available for a Skype call if needed and would appreciate any advice. Take care, Brittany. Okay, so again, I have to be careful here. I know we disclaim it, at the backside and front side of all this. I do not want to be misconstrued as giving medical advice here, but again, general information. Anavar is a good alternative for females who, whether it's for TRT, if you will, for hormone replacement therapy, perimenopausal females, or if the idea is to just simply put on more muscle and lose fat. It's very safe because while it's a dihydrotestosterone or DHT derivative, it tends to be very anabolic without being androgenic, meaning it won't stimulate the growth of hair in the wrong places, loss of hair in the right places. It doesn't bring on what we typically refer to as the male secondary sex characteristics. That includes acne, which of course you say, well, that's not just males. Yeah, it's males and females. But it's what we used to call very clean, meaning very anabolic versus androgenic anabolic steroid. It is one of the few that has research studies showing that not only is it anabolic toward muscle growth, but it's catabolic toward fat. So it can reduce fat while putting on muscle, sort of the holy grail, right, of what everyone wants for the most part. So it's actually a good choice, and it's very safe with women because even though it's an oral, I believe we call it C19, it has to do with where you have another ligand, if you will, on the molecule, and therefore it affects the way it's metabolized in the liver. It's compared to an injectable esterified form of testosterone like testosterone cypionate or enanthate. It's a little harder on the liver. It's relatively lightly so, and it is, again, with emphasis on relatively so, but the dosages we use in females are so small that there's really no effect on the liver, relatively speaking. So it's very, very safe, can be used long term. So I guess one of the answers to your question, use it as long as you need to get to where you need to go. It can be useful in perimenopausal, menopausal women for another reason, which is particularly with females that have experienced estrogen-sensitive cancers. Because it's a DHT derivative, it will not convert to estrogens. So one of the risks is, you might have, say, a 55-year-old female who's had, unfortunately, breast cancer and estrogen sensitive, and she's suffering symptoms of low testosterone. Because testosterone can convert to estrogens, that's not an easy an option, because they would have to continue with an AI or another estrogen blocker, if you will, a SERM, for life, or as long as they were on testosterone therapy. Because there's no conversion of Anavar, which is also known as oxandrolone, it's a great choice. Again, very, very safe. And it also, going back to the holy grail of what most people are looking for, it helps with the muscle gain that you tend to lose as you get older anyway, and the fat loss, ditto, that you tend to gain more as you get older. And as I said, all anabolic steroids, all of them, it's rare you can say that, will tend to raise your bad cholesterol, the LDL, and lower your HDL. I hate to even mention that because in many ways we've learned that it's not as important as we once thought it was, unless you have extant coronary artery disease. But with females, I rarely see it budge the numbers at all. And there's ways, by the way. The other practitioner here and I were talking about just over lunch earlier, Joe Franceschi. We can have someone on an anabolic steroid and actually make their lipid profile look better than when they weren't on it.
Wow.
With things like over-the-counter supplements like niacin, controlled-release niacin, red yeast rice, or effectively a statin. So it's not a concern, is my point. So definitely consider it. As far as human growth hormone goes, we've talked about this before, long time ago, but it's still out there, right? It lives, forever on the internet. Human growth hormone is not legal to prescribe in the United States. It's available for prescription for roughly 7 wasting disorders. And so I can't recommend or prescribe human growth hormone just for weight loss. But to answer the question, growth hormone is very good at the catabolism of fat, if you will. It helps get patients leaner. It also helps put some muscle on, but nowhere nearly as well as testosterone or a testosterone derivative like an anabolic steroid would do. But there are other ways to increase human growth hormone endogenously using secretagogues, which again are not FDA approved, but are available legally now, some of them. GHRP 2 and 6 were taken off the market here purposely by the FDA. But there are others like ibutamorin, ipamorelin, each with their own characteristics, but they can help a healthy body, and certainly a young healthy body, she's 35 years old, they can help endogenous production to the equivalent of roughly 3 to 4 IUs of exogenous growth hormone use. And we judge that again by the IGF-1. Somebody who's 20 might be in the 300, 350 range for IGF-1, and we've seen that with, I've seen things that aren't supposed to happen with ibutamorin. We had a 464 one time. There's supposed to be what we call a negative feedback there, which limits the effect of these secretagogues. So my point is, not only can we do it legally, and I argue in a better way than using exogenous growth hormone anyway, you're telling your body to produce more, so you're not suppressing your own production. You're actually encouraging something that tends to back off over time anyway. And for 1/10 the cost, by the way, which is important too. But it brings up another question. I might as well throw it in here now. Do you really want to raise your human growth hormone? This question has not been answered, and yet I'll give my opinion and just take it as just that, because we don't have studies that's going to say what's right or wrong, and it's an argument that goes back and forth amongst physicians that work in this area. I believe there's a time and a place, like anything else, right? Just like there's no one-size-fits-all diet, there may be a time of year or a time of life, and not to be too Byzantine, but roughly, let's say, up until you're, say, 35, you may want to have an abundant supply of growth hormone flowing in your system for various reasons as to what it does. But then from 35 to 65, because of the risk of, say, cancer proliferation, and your body's doing different things now, it's not quote-unquote growing so much as it is now. It's actually going maybe arguably the wrong direction, and you could argue it might be going the wrong direction even sooner, but maybe you don't want the increased growth hormone and the resulting IGF-1 that typically occurs. And it might not be a good idea to raise it. There are better ways to lose fat. And then you might argue that sometime after age 65, it's best to go back into more of this growth phase because, for example, it helps your legs and hips stay stronger so you don't take a spill and fall down the stairs, which can kill you faster sometimes, certainly, than cancer can. So there's considerations here, and I don't think there's an answer as to whether, it's great to have a higher growth hormone and IGF-1 or not. And there's also an argument there that, as I kind of touched on a little earlier, that maybe it's not even a stage in life thing, or that is not the sole consideration. Certainly, post-surgically, you could argue for wanting to raise it to help, if it's nothing else, just heal the surgical wound. But certain times of the year where you might want to step it up, summertime, like when everything else grows, and then back it off in the winter. So we don't have an answer just yet, one that's cut and dried anyway, as to, first of all, if it's a good idea to all the time raise growth hormone or not, when and how to do it. I'm giving you my opinion. Certainly, though, to answer her question, it would be useful to help get rid of fat and put on muscle. So if she wants to use it as an adjunct to Anavar, great. My suggestion would be, though, to choose one, just to approach it scientifically. If you've got the time, if you're not, 3 months away from your high school reunion, you got to look, great, and not that you don't look great already, but you want to get to that 115 sooner rather than later. Just to see what one does versus the other. If you do them both together, you don't know which is contributing more. So try one and then either get off one and try the other, or then add the other later so you can see, okay, what's doing what. And I would say, though, if you're going to use growth hormone alone, you're not as well off, or a growth hormone secretagogue is what I'm really referring to here, or suggesting. You're better off having testosterone levels that are optimal if you're going to go to the trouble, I'm trying to say, to raise your growth hormone. So I would try the former, the Anavar, first before you try the HGH alone.
Best recommended dosage for girls as far as Anavar?
Everyone's different, but I start gals on 5 milligrams twice a day. That's based upon clinical results, as well as, for the doctors or the people that want to follow along with their labs at home. You find that because of the very short half-life of Anavar, also known as oxandrolone, it's got a 9-hour half-life. It really doesn't show on labs very well. I mean, if you take it and then 3 hours later go get an assay of your testosterone, it might show up as being on therapy and therapeutic. But I go really more on clinical benefits and resolution of symptoms for that reason. It's hard to catch it just right. And even then, you're extrapolating. Okay, how many hours beforehand did you do? It's not worth it. But 5 milligrams twice a day tends to work pretty well for most gals.
Awesome.
Yeah.
All right. Thanks, Doc.